Hello everybody, welcome back here. Matt with you again. So we just finished covering up everything we need to know for the foundation of strokes. So really interesting situation we have here. I have a firefighter and paramedic, MFR, who's gonna share a unique call that they were on. So we're gonna take you through that, and hopefully we can get a few pointers out of it afterwards. So I'll let him introduce himself and we'll take it from there.
Hey everybody, for anyone that doesn't know me, I'm Joshua Henry, firefighter on C Platoon out of Station 45 in Fall River. So yeah, just have kind of an interesting call, hopefully to go through, might learn a couple thing or two and see where we go from there.
Awesome. So Joshua had a call here. I'm just gonna get him to take us through what they were dispatched to, what the patient's chief complaint was. So yeah, Joshua, why don't you tell, we'll take it from the top. What was the call you were dispatched for, and what was the patient's age, chief complaint? We'll go through it all.
Yeah, sounds good. So basically we were going for, I was on Tanker 18, so at Westfall. It was an overtime shift for me. We went for, it sounded like your run-of-the-mill standard shortness of breath complaint. You know, you're getting in the truck, it's like, okay, we do so many of these. But still, I was trying to go through the differentials. What could this be? Is this going to be something life-threatening or whatnot? It was once we kind of got on scene, we had like a 50-something-year-old female. She didn't seem too worked up or anything like that. Normally, like shortness of breath, you expect someone to be like doubled over and really struggling to breathe. I didn't see any of those indications. Didn't seem to even be that anxious or whatnot. So did her assessment and found out that she was actually complaining of kind of like right knee pain, causing like some new mobility for her. So she really wanted us to investigate that. I'm like, okay, what about the shortness of breath? She's like, oh no, I kind of get this on and off. So it was like, okay, so this might not even be what we were actually called for.
Okay, interesting. So you got called for the knee pain to assess that?
Yeah, exactly.
Okay, that's really interesting. So it seems like it's just a basic run-of-the-mill medical assist. We'll do a basic assessment, we'll get some vitals, and when EHS gets there, we're out of here.
You got it.
That's what you were thinking.
That was the mindset anyway. So.
And was there family on scene? Were you able to talk with them at all a little bit?
Yeah, so the patient's husband was there and wasn't able to give us a whole bunch of information. He, again, seemed very calm. Like he's just like, yeah, she's just having trouble kind of moving around. We thought we better call you guys and just get her checked out. It's like, okay, yeah, no problem. And then as I was talking with the patient, I noticed that she had almost, it sounded to me like a speech impediment, and she was not stuttering her words, but just having trouble finishing her words and just getting them out. It sounded like she was kind of like, had like almost like a tick in her speech.
Interesting.
I thought that's kind of strange. So let it go for a little bit, and then something just popped in my head. I'm like, I should ask her if this is normal for her. I'm like, have you always had like a speech impediment, like from when you were younger? She's like, no, it's weird. Like this just started 30 minutes ago. I'm like, oh, interesting.
Okay. Interesting. So at that point, you and your team are shifting gears.
Yeah, so immediately I'm thinking, okay, something's going on with the brain then. We're thinking kind of more neurological.
Okay, sure. So what are some things that you were doing to figure out a neurological assessment? Again, she was only complaining of the knee pain.
Yep.
So this is strictly what you guys picked up. So what are some other things that you did? What are some other questions you asked?
So right there, I went kind of into your Cincinnati stroke scale. So without kind of telling her, I was looking at her face. I was trying to see if there's any facial droop or whatnot. I got her to reach up and grab both my fingers and do the squeeze test, make sure both were obviously the same bilaterally, and then got her to hold both palms up, close her eyes, tilt her head back, and see. There wasn't really any positive arm drift, but even just with the speech, I was like, okay, that's enough to kind of go through that. Tim Cleary, who was on the back with me, he got vitals and came back like 180 on 140, I think was the blood pressure. So she was hypertensive.
Sure.
Again, so that was another kind of check mark in my mind, being like, okay, we got something going on probably in the brain. And I just started kind of going down the road, like, any new nausea, vomiting? She said yes. I was like, any new dizziness, trouble walking? Yes. When did that start? Oh, about the same 30 minutes ago.
Okay, interesting.
And you know what was funny, Matt, is she actually got, not upset at me, but she was kind of like, why are you asking me all these questions? She's like, I want you to look at my knee. And I actually responded, I'm like, I'm not even worried about that right now. Yeah. We're going on a different route. So.
That's right. So again, and we had talked a bit about this in other CME modules, so important to remember a chief complaint working versus a working diagnosis. So the patient was complaining of right knee pain, but you folks picked up a working diagnosis of potentially some kind of neurological issue. So you did the Cincinnati stroke scale, and we remembered our FAST acronym. So you looked at face, arms, speech, and time.
Yep.
You got all that. What did you do next?
So from there, it was just like, okay, we've got enough things indicating to me that this is an acute stroke until obviously proven otherwise. I kind of took a moment just to go talk with the husband again, like, how is your wife normally? Is this abnormal? And that's when you start to get a little bit more of a story, like, oh yeah, no, you're right. Like this morning, she was kind of acting a little bit off. She just wasn't making sense with her words and whatnot. And it's like, okay, good. So now we have some information going. The rest of the vitals, everything came a little bit elevated, I guess. Like her pulse was up, but wasn't really even short of breath, I wouldn't say. Like she was probably breathing like 20-minute. Pulse seemed to be a little bit irregular. She kept complaining of dizziness. Never felt like she was going to pass out per se, but you could see it just in her eyes. She just wasn't able to focus fully. So it's like, okay, yeah, we have something going on, and that's when it's like, okay, we got to somehow be able to notify paramedics in this complete change of direction that we're thinking now.
Okay, awesome. Yeah, so and this brings us into our next point, team. So on our TMR radios, we have a channel called MFR Central. If you flip to that channel on your TMR radio, that will put you in direct contact with the EHS Communication Center. So in this situation, it doesn't seem like the paramedics were too far away. But if you're in a situation where they are, you could flip over there and give a good patient update, because chances are, if it's just for a knee pain, the ambulance might only be responding code 2. So by changing the direction of the entire call, by giving them a detailed update saying, hey, we have a chief complaint of knee pain, but a working diagnosis of a neurological issue, potentially a stroke like in this case, then that gears them to kind of up the ante and get them moving a little bit quicker, potentially to the call. And it also kind of puts a few other things in motions behind the scene. So why don't we talk a bit about now when EHS got there? What did you and the team do, Joshua?
Yeah, and you know, that's a great point. So luckily, we had a really good rapport with the medics that did arrive on scene. It was a double ACP crew. So already I was like, okay, sweet, we have ALS already, because that was my next thing. I'm like, okay, if we're getting just a BLS truck, we're gonna need to request someone else. It just can kind of complicate things. Luckily, I'd worked with one of the medics who showed up. So knew him right away. I came outside, which is kind of something that I've learned to do. If you can kind of put a little bit of distance between the patient and what's going on, I like to kind of go out and meet the medics, whoever's getting out of like that passenger side door, because I know they're probably going to be the one attending. Give them a little bit of a story. They're grabbing their stuff anyway, so they can multitask. And I find they have a little bit more time to listen to you, whereas if you wait till they get right in, they go into paramedic mode and they just want to start asking their own questions.
Sure.
So at least this way I was able to be like, okay, forget whatever notes you saw in the call. This is an acute stroke is what we're going with. And I gave the vitals and everything that kind of supported it, and they both were really good. They stopped, they listened, they're like, no, that sounds fair to us. Let's kind of use that as our jump off point. And
awesome.
They got boom right in there to do their assessment.
Awesome. So in our C&E module earlier in the slides, we did talk about percentages. You mentioned the Cincinnati Stroke Scale, which we did talk about. But out of the three main things we're looking for in our FAST analysis, so facial droop, arm drift, extremity weakness, or slurred speech or speech abnormalities, this patient was only experiencing one of those three.
Exactly.
Which is really interesting, because that leads you to believe, based on evidence and research, there's a 72% likelihood that the patient's experiencing a stroke. So that's a really good pickup by you and the team. And I just want to say you and everybody else did a fantastic job. And we're really happy that the patient had a good outcome. So why don't you talk a bit about that?
Oh, sure. And yeah, like I said, couldn't have done it without the team that we had. Even Captain Creamer, who was our officer that day. As the call progressed, EHS called in. They got their stroke team activation, where they actually call the doc and get approval to go right to the new HI, so the QE2. They were able to use our vitals that we had, which just saved a little bit of time. But Captain Creamer actually said, do you want us to stay and help you kind of extricate the patient out of the ambulance? And they said, no, we're good, because they're just in paramedic mode. They're thinking, yeah, we have a patient here. But I mean, she was a little bit overweight and whatnot. So he said, what if we help stay? And I, sure. So we actually helped bring the patient out, get her all packaged in. And I think that also helped kind of decrease the on-scene time. So I just kind of want to throw that out there too. Like, if you see something that you think can be done better, don't hesitate to offer that, because sometimes we get so focused on patient care, we forget, there's a whole bunch of kind of working bits to that.
Totally. And in a situation like this, time is brain.
Oh, exactly.
So the more time we're wasting on scene, the more the patient's tissues in their brain are dying.
Absolutely.
So that's a great call on your guys' behalf too.
Yeah.
And afterwards, without breaking any patient identifiers, in the circle of care, you actually got an update from a teammate is that the QE2?
We did, and apparently I just completely glossed over your original question, but
That's okay.
yeah, so later on that shift actually, because again, I had that relationship with one of the paramedics, he was able to find out, I think they were at the queue for another call or whatnot, but one of the doctors came out and said, yeah, no, that was a confirmed ischemic stroke. So they ended up giving a medication called TPA, which basically busts apart the clot after they did the CT scan, and they said within 10 minutes all the patient's symptoms resolved. She had no lasting deficits and was expected to make a full recovery. So
Excellent.
that was super cool to get, because normally you don't get that closure. We're like, I think we did all the right things.
right.
I think this is what it was. So.
Yeah. No, that's a really good pickup. So a really atypical presentation here. Again, only really having that speech abnormality. So
Right.
without a detailed assessment and asking the patient those questions, you wouldn't have picked that up. And who knows the urgency of the paramedics if you didn't express that when they got there. So again, really fantastic job to you and the team.
Yeah, this stuff, it's important. So
Yeah.
can save a life just knowing the FAST acronym, really. So.
Awesome, awesome. Anything else you want to add for the team to remember for next time, Joshua?
No, that's great. Just there's lots. Medical field is always evolving, so just make sure you keep up on the studies, and yeah, the little things do make a difference. So.
And if you have any concerns or anything's just not clicking or making sense, feel free to report that to the oncoming paramedic crew, and we'll work as a team to figure out what's going on with the patient.
Yeah.
So keep up the good work, everybody. Thank you very much for everything you do, and thank you to Joshua for coming in and sharing this story, and thank you to everybody who else was on that call. Good job.